The title of my talk today is not only malaria elimination in Asia, but also hyper hope. And I hope to sort of go into a little discussion about whether all this talk about malaria elimination is simply a lot of hype, or whether there's actually true hope for eliminating the parasite here in the Asia region. So just a quick run through in terms of my talk. I'm going to just have a few slides, just a basic malaria background, and then go back in time, focus a bit, walk us through the eradication years, look at the end of the eradication years into control and what I would call the resurrection of malaria control, to the point where people will begin to question whether we can start to use the E word once again. And then finalize, I will sort of focus on this issue of hyper hope. So I think in order for us to start to think about eliminating malaria, we need to understand sort of the biology of the parasite, biology of the vector. I just wanted to highlight some of our malariologists that have preceded us. Dr. Lavarin, who first demonstrated the parasites in patients' blood in the 1880s. Ronald Ross, who discovered Anopheles mosquito was serving as the vector for malaria in the late 1890s, and then Giovanni Grassi, who demonstrated the life cycle for malaria and this cycle between the mosquito and man. So it's important as we look forward to understand, again, where we've gone in the past. So today, or I guess this slide says last year, but we're still faced with a pretty sizable burden of malaria globally. So the World Health Organization estimates that there are over 220 million cases of malaria per year, the vast majority of these in sub-Saharan Africa. Of those, the vast majority, again, in children under 5 and pregnant women, sort of the most at-risk populations within Africa. Of those 220 million cases, we're now estimating that we're seeing about 660,000 deaths per year. A dramatic drop from, say, 10 years ago, but still this very, very sizable number of deaths from malaria. And again, the vast majority of those occurring in Africa. We do see disability in those who survive severe malaria, and that's a problem for society. As well as the economic burden of malaria. And so there are estimates that endemic countries are suffering up to a 1.3% loss in their gross domestic product. This is a map I think those of you working in malaria or familiar with malaria know very, very well. It's just showing where the transmission is. The darker the color in this map, the higher the transmission levels. And so you just draw your attention to the African continent, and we still have severe problems with malaria transmission in Central Africa, West Africa, but you also see in Southeast Asia, especially Burma or Myanmar, we're seeing a lot of transmission still. So just taking us again back, and I wanted to walk through what I say the early years or the malaria eradication period. Now, there's certain events that the sort of public health community went through which began to ferment the idea that maybe we can eradicate this parasite. And I would say that some of the early successes started with the digging of the Panama Canal. Now, vector-borne diseases were a problem for the workers in the digging of that canal, predominantly yellow fever and malaria. And with engineering and vector control activities, we saw a substantial decrease in the number of mosquitoes in that area, which led to a decrease in malaria cases. During sort of the World War II era, we saw the development of chloroquine as an effective antimalarial drug, as well as DDT as an effective insecticide that became more widely available during that time. And the malariologists began to believe that they had the tools that they could potentially use to eradicate this disease. There also simultaneously was the development of, not development of microscopy, but just the entrenchment of microscopy, and folks thought that they would be able to use that again as a tool to diagnose malaria and treat it with the chloroquine. Sort of all of this led to the launching of the global malaria eradication campaign in 1955 at the World Health Assembly. So really, as the public health community were looking at malaria eradication, I think they put most of their eggs in a single basket, and that was vector control. And they felt that DDT used as an indoor residual spraying insecticide could serve as a magic bullet, and that if we, again, had substantial decreases in parasite populations, that we could potentially eradicate this disease. Now, that was based on a few assumptions. And one assumption being that people rested indoors at night, because, of course, you know that the mosquito often in many parts of the world will take their blood meal indoors where the person's resting, rest on the wall that's been sprayed with the DDT, absorb a toxic dose of the insecticide, die. So that was a main assumption. Other activities besides the use of DDT were simultaneously being put in place, and that's mostly focused on case management with antimalarial drugs, using chloroquine for febrile patients, but occasionally also used in mass treatment. And then the sort of development of surveillance to detect and eliminate any substantial or small reservoirs of parasites. So although we often think of the eradication campaign era as a failure, in fact, it was successful in many countries. So if you look at the map on the left, in 1950, you'll see malaria transmission occurring up in the United States, throughout the Caribbean, parts of the Mediterranean area of Western Europe and Eastern Europe, up well into the east coast of China, as well as in these tropical areas that we know where malaria transmission is now. After the eradication campaign, you can see that essentially that map was shrunk. So essentially during the campaign era, a lot of the malaria was pushed down into the tropics from the northern areas and some of the southern areas. So what were the problems with the eradication campaign? Why didn't it work? Well, in looking back, historians and malariologists feel that there were some key areas that were problematic. The first one being technical. So technical, one of the issues was the development and intensification spread of resistance, both to chloroquine as well as to DDT. Logistics was a problem. This was sort of run in a militaristic campaign where we needed to move our commodities from central areas out into the field where malaria transmission was occurring. There were problems with supply chain and the problems with once we got those commodities out, the poor application of IRS. There were strategic problems. Again, this militaristic way of running the eradication campaign led to rigidity. So there was not a lot of flexibility for local conditions, and it was very rigid. There was no research. So when some of the tools and approaches we had started to fail, there was no research simultaneously going on. It was developing ways to overcome bottlenecks, to deal with some of the logistic problems, to develop new insecticides or antimalarial drugs. So there were problems with a lack of research. Then a major problem was, in fact, Africa was not even included in the eradication campaign. I think in the development of that campaign, there was a thought that there was just too much malaria in Africa, that the health systems were too weak, and that the campaign would not be successful. And so there was a thought that they would eradicate or essentially eliminate malaria from the non-African regions of the world and then move later towards Africa. Well, as the successes started to become more and more limited, then you had donor fatigue, and so donor dollars started being transferred into other areas, and so there was a problem with funding of the campaign. And then the final problem that was faced was social cultural. So the campaign did not do a good job of working with the community and getting community buy-in, especially with the use of IRS with DDT, and with a decrease in acceptance of that tool led to a lot of people beginning to reject the use of DDT in their houses. So this essentially led to a shift in policy at the global level. And at the 22nd World Health Assembly in 1969, they officially suspended the eradication campaign. And so it started to move a bit more in talking about control to the point where we could minimize the global health impact of malaria, but not necessarily eliminate or even eradicate it, but just try to minimize its public health impact. This is a less ambitious strategy. and it was not necessarily globally led. So essentially, they turned it over to the countries and said, okay, well, you move now into a control phase. There's a shift away from vector control, away from DDT, because of either resistance from either biological resistance or social resistance to DDT, and a lot more emphasis on case management with chloroquine. This also was occurring about the time of Alma-Ata, and so there was a transition from vertical program more into horizontal primary healthcare programs during this era. Well, the problem is that sort of after that suspension of the eradication campaign, the donor money all but dried up, so there wasn't a whole lot of funding available. The other problem is the reliance on chloroquine became problematic. I think, again, people here who have a background in malaria in the Asia region know that that on the Thai-Cambodian border in the late 1950s, we had the development of chloroquine resistance. Almost simultaneously, that developed in the Amazon basin, and then over time, now we know through molecular surveillance that those resistant parasites crossed over into South Asia, into East Africa, and then spread against the continent to the point where chloroquine is no longer an effective antimalarial drug. And while I don't have a slide showing this, what we do see when resistance entered was a huge upswing in the number of cases of malaria and the number of deaths attributed to malaria. Okay, so then we came into a new millennium, and I say that new millennium actually brought new optimism. And why were this new optimism? We saw the development of new partnerships. There were new funding models available. We started to see increased political leadership around the issue of malaria in endemic countries, and new tools were also being developed and made available to the malaria community. So we just transitioned here from that eradication phase to what I would call sort of a resurrection of malaria control that came about with these new global commitments. So one thing that I wanted to highlight was the development of rollback malaria in 1998. So this was launched by WHO, by UNICEF, UNDP, and the World Bank. And what it aimed to do was establish a global framework that malaria control programs could operate under, would coordinate activities among partners, among nations, mobilize resources from the donor community to establish a number of technical working groups that could provide some technical assistance to countries, as well as the establishment of sub-regional networks. So here we're in Thailand. For many years, Thailand was the base of rollback malaria in Mekong, which was working with the countries in the greater Mekong subregion. We also had the development of the United Nations Millennium Development Goals. So we had global leaders talking about reduction of poverty by 2015. And I think even today, the MDGs drive a lot of what we do in global health. From a malaria perspective, 3 of the goals actually either indirectly or directly spoke of malaria. So goal 4 talked about the reduction of childhood mortality. Maybe not directly linked to malaria in Asia, but certainly in Africa, the #1 killer of children during this era was malaria. Goal 5, improving maternal health. Again, maybe not such a huge issue in Asia, but in Africa, pregnant women, very much a risk group for negative sequelae associated with malaria infection. And then goal 6 was the goal that specifically talked about combating malaria and other infectious diseases. So while we might think, okay, well, rollback malaria, the MDGs, all of this is sort of smoke and mirrors, a bit of fluff by global leaders, it actually provided space in which more technical folks could operate under. And also, again, as was highlighted with one of the goals within rollback malaria, was the mobilization of resources. So in this graph, what you see on the x-axis is, time. So 2000 to 2009, and then US dollars on the y-axis. So you see that in the 1990s and here 2000, there's very little money available to combat malaria. But over the course of that decade, a huge increase in resources. Now, 2 major things happened. One is the development of the Global Fund for AIDS, TB, and malaria. And I think we all see that this region has received hundreds of millions of dollars from the Global Fund to combat malaria. Then also the development of the U.S. presence in the Malaria Initiative, also putting huge amounts of money into malaria control, but other donors getting on board as well. World Bank, Asian Development Bank, the bilateral agencies, all sort of increasing their commitments to malaria control. And this increase in funds actually began to move commodities out into the field, and we saw substantial decreases in morbidity and mortality associated with malaria globally. And with these decreases in morbidity and mortality, then people started to dare to say the E word. And why I say that is when I started my career in malaria, we didn't speak of eradication. We didn't speak of elimination. It was almost a forbidden word. It's like, well, that was the time of the failure. We don't say the E word. This is sort of like, you know, polite people in polite company don't say the E word in the malaria community. Well, I'm not saying that the Gates aren't polite people, because I've actually never met them, but I'm sure they're very polite. But in Seattle, Washington, in October of 2007, Bill and Melinda Gates hosted a malaria forum where they brought together sort of thought leaders in malaria control from around the world to discuss the state of malaria and what could be done about it. And I think one would say that Bill Gates is a big thinker, whether it's his time with Microsoft or his time with his foundation. He has lofty goals, and he sets out to try to achieve those goals. So there are three quotes that I selected that came out of that meeting that I wanted to highlight with all of you. One was from Melinda Gates, which says, "Any goal short of eradicating malaria is accepting malaria." The next one was from Bill Gates. "We should eradicate malaria because we can eradicate malaria." Now, those seem sort of simple statements, but at the time of this forum, I think they were actually quite radical, because up until this point, the malaria community wouldn't say the E word. But once Bill and Melinda started to say it and organize this and convince the people at this forum, then it actually became part of the discussion. Margaret Chan, the Director General of WHO, was invited and attended this meeting, and she, in her comments to the audience, basically dared the audience to come along with them on this path towards eventual eradication. So with this kind of leadership that had not only financial leadership but just thought leadership, the movement began. So Rollback Malaria came out with a statement after that meeting, which basically said that the Rollback Malaria Partnership endorses elimination efforts in countries where it makes sense, where it's appropriate based on the epidemiologic factors in that country. So, for example, elimination would be appropriate in countries that had low burden of disease. Well, that certainly makes sense. That lie near either natural borders, such as oceans, or contiguous countries where there was no malaria transmission occurring, whose leaders were politically and financially committed to the idea of elimination, who had health systems, surveillance systems that were strong enough to be able to manage the process of a malaria elimination campaign, and where sort of the biology of the parasite and vector, it made sense given the tools that we have available to us today. So with this movement, Rollback Malaria worked with global partners to develop a global malaria action plan. And that global malaria action plan was a strategy that countries could look at and utilize to try to move them towards the eventual elimination of malaria. Acknowledging that malaria still is occurring in a huge number of countries around the world. Acknowledging some of the mistakes, perhaps, of the eradication campaign, they specifically said that malaria control should be country-led. The strategy should be developed at the country, not necessarily at the global level, but that it should be internationally supported, either through frameworks like Rollback Malaria or from the donor community. And in the Global Malaria Action Plan, or the GMAP, there were three main components. One was control, and control being split up into two parts. One was scaling up for impact, SUFI, scaling up for impact. So what does that mean? Taking the tools that we have, such as bed nets, such as ACTs, diagnostics, and scaling them up to the point where we could actually do something with that. And scaling up not slowly, but rapid scale up. and then sustaining that over time. And that was important. So you scale it up, you get high coverage of these interventions, and you keep them, and you drive the parasite burden downwards. The next thing that they looked at is once you moved beyond the control phase, that you actually have elimination. So they were not afraid to use the E word in the GMAP, that we can talk about elimination. Talk about control will lead towards elimination. This is the path. And then again, recognizing some of the mistakes made during the eradication time, they ensured that research was present in all aspects of this, so that we, again, can look at what's working, improve on things that are working maybe not as quite as well as we'd like, and then also be agile enough to develop any new tools and approaches that may lead us towards eventual elimination. So if we just take a step back and talk about definitions, because we're talking about malaria control, we're talking about elimination. I just wanted to highlight that and make sure that we're on the same page. Is that malaria control, again, either through scaling up for impact or sustained control, is essentially reducing the disease burden to the point where it's no longer a major public health problem in the country. Right? So we want it, it's still there, but it's not a major public health problem. And I might say that in certain parts of Asia right now, that's what we're looking at. There are discussions I've had in the past with malaria control program managers in Asia, and they'll talk about malaria because they know I have a background in malaria, and they say, well, can we talk about dengue? Because for them, perhaps dengue might be a larger public health problem because they've done such a good job in controlling malaria. Now, elimination, when we talk about elimination, this is actually interrupting locally acquired cases of malaria, locally transmitted malaria in either a defined geographic zone, subnational region, a province, a district, half the country, or at the national level. So no locally acquired cases, only imported cases in elimination. And then eradication, of course, is essentially elimination on steroids, where we've eliminated it from every country, so it's no longer exists worldwide. So with all this movement, with funds being available, with people not afraid to talk about elimination, we began to see the development of guides and approaches and tools for that. And here's just a few that I pulled together that were developed by WHO, the Malaria Elimination Group at UC San Francisco. Things that either national programs, that development partners, funding agencies can use to try to help to steer towards successful activities in malaria elimination. One of those was a guideline developed by WHO on malaria elimination, and I think this is an important graphic because it's a graphic that a lot of malaria control programs now pay attention to, and that's how you transition from control towards elimination. And so what WHO was suggesting is that you are essentially in your control phase up until the point when about 5%, and I say about because these aren't hard, fast numbers, but they sort of serve as a reference, but about 5% of your febrile patients presenting to a health facility are diagnosed with malaria. So in my early days in Africa, we used to say, before diagnostics, we used to say, okay, about 50% of febrile children presenting to the health facility have malaria. Well, obviously that's too high to move out of the control phase. But once you actually have reduced the burden to a substantial level, then you start moving into a pre-elimination phase right here. And it's essentially pre-elimination phase, I think, is a bit more, it's sort of intensified malaria control, but you're moving towards the point when you're trying to reduce your annual parasite index or your incidence of malaria to less than 1 case per 1,000 population at risk. So if you meet that benchmark more or less, then WHO would consider that you've moved into the elimination phase and you're actually looking to get to the point where you have no locally transmitted cases of malaria. And then if you can, in fact, prove that you've had no locally transmitted cases of malaria over a 3-year period of time, you can apply to WHO. They'll send an international team in to certify that you've, in fact, eliminated malaria from your country. So this shrinking of the map issue actually isn't necessarily a new idea. It has been going on for some time. And these are just old posters from the eradication campaign again just trying to get the population motivated. So here we have just a sort of a BCC poster. Down here we have some postal stamps from different countries. They're highlighting the vector. And here we have a poster of United States efforts to eliminate malaria, which was originally called the Malaria Control and War Area. So the U.S. Public Health Service, which is based in the Washington, D.C. area, as they were moving towards eliminating malaria in the United States, I thought they made a rather bold move saying, well, rather than coordinating these efforts out of Washington, out of the nation capital, we're going to move our malaria control program out into the field. So in fact, they moved the malaria control program from Washington out into the areas of the United States where malaria transmission was occurring, which was in the southeastern part of the country at that point in time, and developed our malaria control program. Well, that malaria control program eventually became the CDC, where I now work. So when my friends in Atlanta complain about being in Atlanta rather than Washington, they look at me and they say, it's your fault that we're actually in Atlanta. But that's ancient history. So in 1900, the malaria transmission map looked like this. Doesn't mean that all parts of the countries had malaria transmission, but those countries in red had malaria transmission going on. And so over time, 1945, we saw a slight decrease, shrinkage of the map, but not a major shrinkage of the map. But when we went through the eradication period, as I already pointed out, then we saw countries, mostly in the north, beginning to be free of malaria, and then by 1990, increasingly shrinking the map into the areas where we now know the malaria is transmitted in the tropics. Today, where are we? In this map, the green countries have eliminated malaria. The blue countries are in that process of working towards eliminating malaria. And then the red countries still have a ways to go before they can have substantial discussions around elimination. So we're here in Bangkok. The talk is supposed to be not about CDC in Atlanta or about malaria in Africa, but rather malaria elimination here in Asia. And whether there's a lot of hype, we see a number of talks at this meeting and other meetings around the region talking about malaria elimination. Is there a lot of just hype, a lot of hot air around this, or do we actually have real hope of being able to eliminate it in this region? Well, if we looked at the WHO websites, I pulled these off off the websites in preparation for this talk. We look at the Southeast Asian region. There's 11 countries in the Southeast Asia region, and they're saying only one has eliminated malaria, and then 2 are sort of in the pre-elimination category. Linda Ortega, if I'm wrong, it's your website, you have to update it, so talk to me later. Western Pacific Regional Office is a bigger region, a lot of island nation states, 28 countries. 18 have thus eliminated malaria. 2 are in that elimination category, moving forward, and the rest are still in control mode. So if we look at it a little bit differently, and we look at API, and again, we want that API to be under 1 case per 1,000 at risk. We look at a number of countries in the Asia region here, and you see APIs going as high as 11 down to very, very low APIs. And I'll just help us orientate ourselves with the next click of the mouse. This is an API of 1 per 1,000. So we actually can see here that based on API as reported to the World Malaria Report, we see a number of countries down here. They're actually in that area where they can considerably talk about and move towards eliminating the parasite. So while there are certain countries, such as Burma or Myanmar, that still have quite a high parasite index load and are clearly not ready to engage in discussions. They can engage in discussions, but engage in activities related to elimination are probably still very much in the control phase. We have a number of countries in the Asia region that can and should be moving towards elimination. Well, the good news is that they are talking about it. So they know this. They don't need me to stand up and tell them this. And they've formed a network. I had the pleasure of attending the inaugural meeting of the Asia Pacific Malaria Elimination Network in Australia. And there are a number of countries in the Asia region that have committed themselves to working towards elimination. This is just a map that sort of highlights many of those countries that are belonging to JITMM. So, of those countries that are part of JITMM, what goals are they setting for? So this schematic looks at national and subnational elimination goals. And I'm just going to walk us through a number of countries so you get an idea of where people are right now. And this is so by 2014, Sri Lanka has committed itself to eliminating malaria by 2014. The Philippines are moving towards not a malaria elimination by 2014, but essentially eliminating malaria deaths by 2014. And then some of the island nation states in the Western Pacific Regional Office, specifically Vanuatu and Solomon Islands, are committed to eliminating malaria in certain provinces within their countries. So we look further, the Republic of Korea, that certain parts of Malaysia, certain provinces in Indonesia are committed to eliminating malaria by 2015, Bhutan by 2016, China, the Philippines, and additional provinces in Indonesia by 2020, all of Malaysia by 2020, that Thailand would be 80% malaria-free by 2020, Cambodia 2025, Vietnam 2030, and then all of Indonesia by 2030 as well. So these are ambitious goals. We may or may not reach those goals, but I think it's important that the countries talk about it and put it and those goals out there so that they can actively work towards it. Just looking at a few different countries, maybe schematically, and we look at China, and each of this map in China is divided into different counties in China. And you can see that the color is white being no malaria transmission, yellow and green sort of being at that level where they are actually in the elimination phase, and then red probably still somewhat above that level where we can look at elimination. You can see other than just a few counties in China, the vast majority of the country is at that point epidemiologically where they can and should be working towards eliminating disease. And as you saw with their participation in JITMM, they are in fact doing that. South Korea had all but eliminated malaria, but during the late 1990s, they saw a resurgence of vivax malaria near the DMZ with North Korea, and that caused a reintroduction of that. And I think this is an important slide because it illustrates that once you eliminate malaria, the job's not over. Is that you've got to work towards preventing a reintroduction of malaria. Whether we talk about South Korea, whether we talk about Jamaica, which had a reintroduction of malaria after having eliminated it, or whether we talk about the United States and why malaria branch within CDC still exists, is because we take very seriously any report in the United States, and we occasionally get those reports of a locally acquired case of malaria. So we still occasionally have malaria transmission occurring even in the United States. We look at Sri Lanka. Here is a graph of disease from sort of 1910, more or less, at this part of the axis down through 2010. You saw during the eradication era a dramatic decrease in cases, almost having eliminated it, but with the funding drying up, a resurrection of cases beginning. And what I want to do is highlight sort of this area at the very bottom. And you can see that by 1999, they had over 250,000 cases, and down to 2011, they reported, 116 cases. So not quite eliminated, but very, very, very close towards having eliminated malaria. And just a few key events that have happened over the last decade. This map Sri Lanka shows that, again, in 2000, you saw a lot of malaria transmission occurring and then over time, really a reduction of that. So what we're hoping for is really by 2025 is that we see really a number of countries, if you see here in Central America, joining the elimination countries, and certain parts of Asia as well, having eliminated the disease. This schematic shows really, it's interesting. On the x-axis, we look at relative technical feasibility mean rank. So how, given the nature of that country, is it feasible from a technical standpoint to eliminate malaria? And on the y-axis, operationally, is it feasible? And I've circled some countries in the greater Mekong sub-region, and it gives us an idea, sort of based on, either the technical or operational feasibility, where they may be. And you'll see that we have a few countries down here, China and Vietnam, that are quite feasible, that they may be able to eliminate malaria in the near future. And then places like Burma and Laos, where there's some still challenges that need to be addressed. So many of you may be movie fans. I'd like to use the term "Back to the Future," and the future is the past, and that's engaging in the discussion and using the E word here in Asia. And I say, are we ready to begin using the E word in Asia? Well, I hopefully have made a case that I think we are there, because we have seen unprecedented commitment, at least perhaps since the eradication era, both financially, politically, and technical, to eliminate the parasite. We see a strengthening regional economic environment. I say that's important. If you look at the history of malaria control in the United States, one may say, okay, it's the movement of malaria control in war areas, or the predecessor of CDC getting into the field, coordinating malaria control activities, the onset of vector control activities, and so forth. But on the other hand, we might say that it was simply economic development. So if you look at malaria, say in the 1800s in the United States, it was well up into the eastern seaboard, into the Midwest of the country, California. But as those areas developed economically with the Industrial Revolution, it sort of pushed malaria down into the rural South. And it wasn't until the rural South economically developed that we saw a real cessation of malaria. So the fact that the Asia region is really developing from an economic standpoint is very important. This also leads to a strengthening of health systems within this environment. Now, there's still some weak health systems. I'm sure that, we can have discussions about some of the countries in the region and the state of their health systems, but they are moving in the right place. Another key component here is this issue of decreasing civil and armed conflict. I think the changes that are happening in Burma right now are very significant. The fact that we're having a cessation of armed conflict in much of that country is important. The same with Indochina and the countries there. That with the cessation of conflict, then the malaria control activities actually could go in and start to have some substantial impact. All is not without debate. I mean, in the public health community, and certainly in the malaria community, there are debates. And I understand, I wasn't here this morning, but I understand that one of the earlier sessions was exactly that, to talk about debate. So we have an old debate, and this debate, when I was in graduate school, was raging. I went to Johns Hopkins, and I had the pleasure of studying under Carl Taylor and D.A. Henderson. Carl Taylor was the father of primary health care, one of the authors of Alma Ata, Health for All by the year 2000. D.A. Henderson, of course, coordinated the eradication of smallpox, and both of them were vying for the young minds of the graduate students. So eradication versus primary health care, an old debate. So how are the global and regional goals and local priorities balanced? Should we be focusing our resources on elimination or eventual eradication? Who benefits most from disease eradication? What are the costs? Who's going to pay? Is it sustainable? Should the Asia region focus on a single communicable disease? Hundreds of millions of dollars on a single communicable disease. Some of the countries are only leading to a very small number of deaths. With the economic developments, there's an epidemiologic shift occurring away from communicable diseases to non-communicable diseases. My guess is this conference 20 years from now we're going to be talking about cardiovascular disease, cancer, strokes. Are there competing health priorities out here? All of these very, very valid things to think about when we're talking about elimination of malaria out here. But the one thing that's happening, I think everybody knows out here, that's keenly important is artemisinin resistance. So we don't have a lot of malaria out here, but we have the world's most dangerous parasite out here. There are parts of Western Cambodia where we are simply running out of drugs to treat it. And if we don't eliminate that parasite will replicate, and we will not have tools to treat. And when that happens, that will spread, and that will lead to a dramatic upswing in morbidity and mortality. So I think the paradigm is different than other places because of this issue of artemisinin resistance. That's the old debate. Now there's a new debate that some of you may or may not know about, which is what I call more is better versus new tools and approaches. So there's a camp out here in Asia that talks about more is better, which we talk about, well, we need to do control activities. We need to still scale up. There are parts of the greater Mekong region that still don't have adequate coverage of our interventions. So how can we talk about elimination when we haven't even done the job of scaling up those control measures that we have? Early diagnosis, prompt treatment. A lot of people still have delays in treatment. Effective vector control. Do we use focused IRS? What is our coverage? How effective are long-lasting insecticide-treated nets? How about insecticide-treated hammocks for mobile populations that go into the forest and sleep there at night? What's the role of spatial repellents? Have we done enough with social mobilization and behavior change communication? What about the role of surveillance, either passive or active surveillance? So one side of the debate will say, we need to do these better. The other side of the debate will say, this is not enough. This is important, but we need to, because of the emergency associated with artemisinin resistance, we need new tools and approaches. We need new epidemiologic measures to seek out mobile and migrant populations, such as respondent-driven sampling techniques. Do we think about screen and treat? Either mass screen and treat or focus screen and treat? Do we have to use more sensitive diagnostic tools such as PCR? And if so, what kind? Real-time PCR, pooled samples of PCR specimens? Do we need a PCR that can go out into the field, be at sort of point of care as opposed to in a capital such as Real Lamp? What's the role of serology, mass drug administration? So I'm sure that in this conference and in some meetings previously, these debates are alive and very well. And they're good, vigorous debates, and that will, I think, really lead towards assisting the Asia region in moving forward towards elimination. So my final slide is just to say, what about Vivax? So a lot of the discussions when we talk about elimination of malaria in the greater Mekong subregion, I won't say all of Asia, because I think JITMM does a pretty good job of including Vivax in their discussions. But when we talk about it in the greater Mekong subregion, we often forget about Vivax when we're focused on artemisinin-resistant Plasmodium falciparum. And so at some point in time, Vivax needs to be part of that discussion.